Good afternoon. Welcome to this PCR session sponsored by Polares. We are here to discuss a very interesting topic, alternative solution to treat mitral insufficiency with a transcatheter device. I think there is no surprise to anybody that we do have interesting solutions that can treat FMR. I think you all aware that, and you are exposed to TEER devices that perhaps can take care of 2/3 of our patients, but there is still an unmet need in at least 1/3 of the patients that we have in our hospitals with mitral insufficiency. And there will be many studies that you're going to be at PCR and in the future testing other percutaneous solutions, and perhaps transcatheter total replacement is certainly a good option. However, you are very aware that in some cases the anatomy can be very challenged, and you're going to experience a small outflow that you can obstruct with a total replacement. So we are here to discuss an interesting solution, which is a partial replacement, posterior augmentation. And now we invite Bernard to invite the first speaker. We have an excellent panel to discuss this topic with you. Besides Azim, we have Nina, we have Thomas, Martin, and some very good speakers as well. Bernard?
So thank you, Alex. This is a very exciting area, and this is a very exciting new technology. And we are a small room here, so please feel free to ask questions. There's a microphone in the main corridor there, and we also have the app tool if you want to send questions here and make them a little bit more anonymized. So Azim is going to be our first speaker, and Azim is going to lay out the landscape and define the need for new tools to treat the clinical problems related to primary and secondary MR. Azim.
Thank you, Bernard. Thank you, Alex, and the Polares medical team for the opportunity to present here. So a little bit we wanted to talk about, and I think Alex hinted a little bit on this, is there a need for other transcatheter approaches? Many of us use TEER, and we feel like sometimes we can do everything with TEER, but I think sometimes when you have a hammer, everything seems like a nail. And so I'm going to try and convince you that maybe a toolbox is going to be important. I am on the scientific advisory board of Polares. So this is kind of a landscape. I mean, I'm sure I'm missing some devices. So if your device is not on my slide, I apologize. I wasn't trying to offend you, but this is generally most of the devices that are being implanted in patients. Some of them already have gone into a graveyard of devices that are no longer there. But basically, we have edge-to-edge devices. We have a flurry. As you can see, I couldn't fit them on one line of valve replacement. We have chordal repair, we have annuloplasty, and now we have this whole sort of area of hemi valves. So how do we think about all these different technologies and fit them in? Well, we have the two main ones, right? We have TEER, and now we have two approved devices in Europe for TMVR. And TEER is great because many of us feel that we can treat many patients for it. TMVR may be a little less so, a little bit more selective. With TMVR also, there's issues like bleeding, afterload mismatch, thrombosis of these large devices. But it does get rid of residual MR and potentially can allow future therapy. But again, why do we need these technologies if TEER is so widespread and so excellent? Well, when you really look at the data and you look at it a little in more detail, we do see whether we're treating primary MR or secondary MR, there's still a lot of patients who have residual mitral regurgitation. And I think all of us are realizing that residual mitral regurgitation is important. When you look at registry data from all these large registries, patients who have moderate residual MR do worse. Our objective should be not to accept the fact that, we have technologies that leave moderate MR and that should be our target. We need to more tailor our therapies to our patients with the hope that we can reduce MR to as much as possible, because that's what impacts patients. That's what impacts mortality, heart failure, hospitalizations, and keeps patients well. So when it comes to TEER, we, thanks to Scott and others, we have all these great criteria about what's a good case, a green case? What's a complex case? What's a prohibitive case? You know, the green zone patients are the ones most of us feel we can treat really well with TEER, and TEER may do well in these cases. And I'm not going to go through the entire list. They're then the more complex cases where the experienced centers say, oh, we can do these. We don't often see the data from all of these, and we don't know how many of these patients end up with residual MR, leaflet damage, or high gradients. But, you know, a lot of centers can't get good results on patients who are in this yellow zone. And then we have those red zone patients that are bad for TEER, and potentially this is where we think TMVR may fit. Well, TMVR, yes, it may fit, and we do have devices, but the challenge is really high failure rates and screening failure rates. So there's some devices and some studies I'm involved in where it's 80 to 90% of patients get screened out. They're not good candidates because either the annulus is too large, they're at risk for LV outflow tract obstruction, there's some anatomical factor that makes them not a good candidate. And we've seen this from multiple registries where many patients are screening out for anatomical reasons. Well, that's where I want you to think about new technologies like Polaris and posterior leaflet augmentation. Could it fit a lot more patients, and could it fit an anatomical subset that is much larger than where we've done all this investment in 12 different valves? So when we look at and we say we divide MR into complex anatomies and non-complex anatomies, and most of us will treat non-complex anatomies, we kind of right now feel like, TEER is the gold standard when we have those green zone patients, right? And maybe TMVR is for those patients that are in the red zone, but the exclusion rate is, like I said, anywhere between 60 to 80%, potentially more. So where does the Polaris and Hemi valves fit in? Are they just going to be in that group where we think, okay, you can't do TEER, you can't do a TMVR, and now we think of Polaris? It's interesting, and you'll see today some of the data that they have a very high inclusion rate. So I'm challenged when I look at this data to even force myself to think, could Polaris or Hemi valve be across the spectrum? Could it potentially treat patients who are early as well as patients who have more complex anatomies and not just pigeonhole it into more complex anatomies? And what are the potential benefits of a Hemi valve like Polaris? Well, I think it preserves the anterior mitral valve leaflet and maintains a physiological LVOT and subvalvular apparatus. It potentially can treat a lot of anatomies that are unsuitable for TEER and TMVR. It certainly has a lower profile, and so it's not extending into the LVOT and potentially will not cause gradients. It also has smaller delivery catheters. Some of the TMVR technologies are 35 French going across the septum. And also, and I think this has come in the discussion, could it leave future options open? Could you still be able to do another technology in the future? And so when I think of some of the obstacles to TEER and to TMVR, I wonder, I think that'll be part of the discussion today. Could a Hemi valve, could Polaris address a lot of those limitations of TEER? Could it address also a lot of the limitations we have with TMVR? So I'm going to finish there, and I think for me, when I think of this technology, I think it's novel and promising. I think posterior leaflet augmentation has the potential to address a lot of complex anatomies without many of the limitations encountered by TEER and TMVR. It's, however, I don't want us to think of it only as a technology that's in complex patients. I think we have to open our way of thinking and see, can we extend this even to other patients where it could be a first-line therapy, because there are many advantages of a technology like this. So I'm going to stop there. Thank you so much.
So thank you, Azim, for setting the stage so nicely. We're now going to drill into a little bit more detail and learn a bit more about the Polaris device. Uli Schaefer has had extensive experience with this, and he's going to give us the device design and also some of the underlying physiological concepts. Uli.
Thank you, Bernard. So I think Azim perfectly set the stage for that interesting technology, so I'm happy to present you the design and concept of that Polaris technology. These are my conflicts. As a quick reminder, actually, there is a surgical concept that has been developed almost 20 years ago called MitralFix that worked quite nice. It's CE marked, but somehow it never really entered the clinical reality. Nevertheless, the company at that time called Middle Peak thought of building up a catheter-based solution that is more or less looking like the MitraFix. So this is how the device is looking. You have here a side view and a top view. So we have a device that is basically sitting on the posterior leaflet and is extending the posterior coaptation to the anterior mitral leaflet, thereby closing the gap in functional mitral regurgitation. And this is one of the first sheaths that had been implanted, where you can see the device that is anchored with screws on the posterior annulus extending into the mitral valve and thereby sitting on top of the posterior leaflet. Here you can see in that animation, this is an in vitro heart, it's accelerated speed, that's why the movie is looking a bit awkward. So after transeptal puncture with a 26 French sheath, the device is steered to the posterior side of the mitral annulus, and then the primary anchor is inserted into the P2 region, precisely in the middle of the P2. And then we have these tethers where the secondary anchors are kind of steered down with guide rails and then the screwdrivers to orient the device then in the perfect orientation. And then the anchors are drilled into the posterior annulus, and you can at that time assess the efficacy of this device. But that is also then the time where you have to take the decision if you want to release the device. So that's the point of no return. So you look for efficacy, you look for mitral regurgitation reduction, you look for potentially significant gradients, and if you don't like it, you can go backwards. So at that stage, the device is fully reversible. And once you decide to continue, then you just continue with the full anchoring of the secondary anchors, and then you detach these screwdrivers each by each, and the device is then completely released. This is the first case that was done more than 5 years ago in Hamburg by myself, actually. Was a compassionate use patient. She was not amenable to any other technologies available at that time. We had an attempt of MitraClip, but there was a gradient, so we aborted that procedure. And I just want to show you the result after this first generation device. At that time, there was only a single size available. And you can see that with this first generation device, reduction of mitral regurgitation was quite sufficient, and also the gradient was 3 in that particular case. During the subsequent phase with that technology, 18 patients in total, we quickly learned when we used then larger devices that we could address mitral regurgitation quite efficiently, but to the expense of gradient formation. So we had to retrieve 50% of these devices, and so the implantations had to be aborted. So quickly from there, the concept of having something that is adaptable or active as a cooptation element arose. And so basically you can see that in this drawing on the lower side, that during the cardiac cycle, this ACE, consisting of bovine pericardium, is deflating during diastole, thereby opening the mitral, and inflating during systolic phases, thereby increasing cooptation. Here you can see that. Again, now this is showing you the 3 steps. It's a 3D-driven implantation. And on the right side, you can see the frame with the ACE on top that is coapting against the antemitral leaflet, thereby increasing cooptation. So far, in the EXPLORE study, what is the first in human study or an early feasibility study that is conducted in Georgia and Brazil. Nina is going to present the data later on in this session. 45 patients have been treated. And besides that, there have also been a couple of compassionate use cases addressing degenerative mitral regurgitation. Besides that, there's also now an ongoing process regarding getting ready for the EFS in the United States and a pilot study in Europe. I just want to show you, as the last slides here, the last case we did in Georgia. It was a patient, 60-year-old female patient with functional mitral regurgitation. Here during general anesthesia, there was less mitral regurgitation, but still she was very symptomatic. And you can see that we address in these cases more or less mainly central mitral regurgitation. You can see that there is MR, and what we also do in all these cases, we need to have a CT scan to do the planning regarding the size selection. Now we have 4 sizes available, and this is the device, how it looks. This device was implanted in that particular case. And you can see here on the right side, if we look from below, you can see nicely this ACE, what is fully open here, and that is the part that is coapting against the antemitral leaflet. Here, these are the fluoroscopic views. So the device is implanted under the guidance of echo and fluoroscopy, and you can see here the primary anchor insertion, then the engagement of the secondary anchors, and then after you check that the coronaries are free of any interaction with the anchors, you release the device. So here you can see the result after this implantation. You can see that the device is nicely sitting inside the anatomy, and there is virtually no mitral regurgitation in that particular case, and the mean gradient of 1. You can see in these 3D images how nicely the device is opening and also reducing mitral regurgitation. And that was also in that particular case the case at 30 days. We can see the same in the TEE that was obtained in that case, and still no mitral regurgitation and a gradient of 2. With that, I'd like to finish and to conclude. The posterior leaflet replacement with Polares MRace is an intuitive and safe intervention, since assessment of hemodynamics and gradients are accessible before release. So we can always go backwards until we reach the point of no return. The clinical study, what is Nina going to show at the end of the session, is currently investigating patients with functional mitral regurgitation. Besides that, we have now also a couple of degenerative mitral regurgitation patients, and this is also one case that we are showing at the end of this symposium. So in summary, I think this technology might evolve as a true competitor in the field of transcatheter mitral devices. Thank you.
Thank you so much, Ulrich. Nicely presented. It's novel technology. It's good to take some time for you to understand the mechanism of action. We're going to start with questions from the audience. Please feel free to come to the microphone. And I think Bernard has a question, a remote question.
Yeah, thanks very much for the question. It's actually directed to you, Azim. You rightly emphasize the fact that this device leaves the door open, and you said for TMVR. Mm-hmm. But does it also leave it open the option of a subsequent tier if we take it the other way round?
I'm not sure. I'm not sure you can grab onto the actual device, for the posterior leaflet. I'm not sure if anybody in the company maybe can answer that, or Uli. I do think, though, you can do TMVR through it. Mm-hmm. I think you could push away the posterior leaflet sufficiently to do it. But again, hopefully you don't need to. Right, because a lot of the patients we're treating here are going to be functional MR with heart failure, and decrease in the MR is going to be sufficient for them. But I do think, compared to the thought of having to do elastic clips and grad clips and try and remove them, pushing this out of the way would be easier with a valve.
But you've also emphasized rightly the complementarity of these different techniques and the toolbox concept. So working out how they can interact with each other as part of a sequence of treatment options is important, right?
Yeah, absolutely. I think we have to change our way of thinking when it comes to mitral regurgitation. We've just had TIA for such a long time, and that for many people they think that's all they use and that's all they need. But the more we treat patients, the more we see increasing complexity, the more we see patients who are not good surgical candidates. And I think we need to start thinking like Thomas over here, like when he's, as a surgeon, when he looks at a valve and he looks at the anatomy, he's not always doing the same operation. He's not always replacing the valve. He's not, he tailors the procedure to the anatomy to get the best possible result.
So that's a nice link to Thomas. Comments, please.
When as a surgeon, probably these are patients you presented in your presentation which are too high risk. But I consider the heart team meetings where I am, and some cardiologists say I can clip everyone. And I think we need to step away from that. And this system offers the perfect solution in a patient who eventually has a very restrictive posterior leaflet or even calcification. Calcification is a topic we haven't looked extensively at, have heavily annular calcification may exclude a mitral clip. You come to too high gradient, and this is a good option to treat this patient. And Uli made it look pretty simple in these images that he was showing.
It is actually simple. I tried to emphasize a bit. So there's two steps which are important. You have to choose the right transeptal location. That's an anterior and 3 centimeter above the annulus location. That's a bit tricky. But if you really find this position, and then the second step needs to be then that the primary anchor is precisely in the middle of P2, in the appropriate distance to the hinge. And this is echo. This is mainly echo-driven, and if you have good echo imaging, then the subsequent steps, they follow by themselves. So we have these tethers, the guide rails are following, so we don't really have to steer much. Everything is kind of preset, and you just have to bring down the anchors, you drill them in, and it's pretty easy. It looks complex, but it's rather easy.
Only a quick question. I mean, what is the average procedural length, time for a procedure, and what's the learning curve?
Now in this study, we have like a procedural time of 1 hour, plus minus 10 minutes. So that's pretty consistent. So I think that's pretty much like a mitral clip.
So we've got lots of questions here, which I'm very pleased to receive. And please don't be shy if you want to come to the microphone. It's also an option. But the first question is an easy one, Uli. Durability. What do we know so far? I know Nina will cover the series, but what's the longest surviving patient?
You have 2 years patients out, but besides that, there's nothing.
Okay. And then the next question is from Dr. Boone. It's a very detailed question, so I'm going to read it. Does the device change the systolic force on the posterior leaflet? What is the role of the cords on the leaflet with this device? And could there be any problems with the posterior annulus over the longer term?
Good questions, tough questions. I can't really fully answer them because it's not known. The posterior leaflet is more or less passivated after this device is implanted because the implant is sitting on top. So the experience so far we have is mainly on functional patients. So in these patients where we have short leaflets or even tethered leaflets, which are mostly the problem for mitral regurgitation. And that's where this device makes perfectly sense. What this device does to the annulus, I think it doesn't affect the annulus because we're not cinching, we're just anchoring with these 5 anchors. So the annulus stays preserved, more or less preserved.
Can I give you my take on durability? Actually, like when we repair a valve in surgery, we use an annuloplasty ring, and the anterleaflet is doing the whole story. It's like a trapdoor, and the anterleaflet is doing same over here. The system is more or less slightly moving, but in the end a passive thing. So there's not much that can get unfunctional. It's not like a clip that can tear off. It's just there, and the anterleaflet does its job. So durability, I would expect a good durability.
Yeah, and the other good question is about, is the screws remain for a longer period of time? Because I did the first treatment for millipede, if you remember. So millipede is a totally different device. Is the device that really try to decrease the annulus size, remodel the annulus size. So there's a lot of force against keeping that device in the same location. Different from this, that you just screw and it sits there. There's no other too much force to try to put it away. So, Mark.
I strongly agree with the comments that we need more tools in the toolbox for transcatheter mitral valve repair. I mean, our center was involved in Medtronic's posterior leaflet augmentation device, the Half Moon, now discontinued, but it was very clear to us that, posterior leaflet augmentation has really some sweet spots, like atrial functional MR, where, you often have, separation or horizontalization of the leaflets, and edge-to-edge repair can put a lot of leaflet stress by bringing the leaflets together. Posterior leaflet augmentation there is sweet because you really restore that coaptation without the stress. Small mitral valve areas, as Tommy has said, deformed posterior leaflet, like tethered posterior leaflets, calcified posterior leaflets, big posterior leaflet clefts. We sent actually 10 patients to Jacques to screen, to look at our TMVR patients and how many would actually be suitable for Polaris. And 80% of our patients ruled in. So I can confirm, whereas like for transcatheter mitral valve replacement and other trials, we've never had that kind of screen in. This is, a new kind of suitability threshold.
So just one final question, Uli. I think you told us already, but a CT scan is essential up front for planning the procedure, determining the circumflex anatomy, etc.
Yeah, that's what we do now. It's not clear we need this in the future. We try to simplify it, but now we want to have a CT.
Wonderful. I think I have more questions, anticoagulation, etc. I'm going to save it for Nina. Okay, Nina, when you present your data. But now, again, it's my pleasure to present Fábio Brito, who's going to share with us an interesting case from São Paulo, a recorded case we did together.
Alex, Bernard, colleagues, good afternoon. It's my pleasure to present you a case. I think it's going to illustrate very well some of these limitations of TEER and TMVR that we're just discussing. Okay, so this is presentation of the team that is going to work in this case, the team from the Heart Institute in São Paulo, me, Alex, and all the team. And I think the case will be presented here in slides. So it's a 71-year-old male with ischemic severe MR with previous CABG. Oh, let me go back to previous CABG and very symptomatic and high risk for surgery. So this is next. You're going to see the echo images with a torrential mitral regurgitation. You can see here, and I think it will point out that it's very short posterior leaflet, as you can see here, very, very short. And also there is calcium in the posterior, this short leaflet here with a lot of calcium and a very wide jet. So maybe you guys can comment on this. Is it clippable or it's a good case, a bad case? What's your take, Kazim? Okay.
Azim, if you would get this case for clipping, you wouldn't be happy about it. So it's a really good case to think about different options.
Yeah, so this is all to demonstrate, showing the images. And again, besides that, this case had an opening area very small. It was 3.6 squared centimeters. So besides this short posterior leaflet, calcium at the posterior leaflet, a very wide jet, and also a small opening area. So it was kind of very hard to think that a clip or a mitral clip or a Pascal would have a good result in this situation. I think so.
Especially probably you're going to need multiple devices, right? So you're going to create mitral stenosis, even if you could clip it.
Yeah. Mm-hmm. Okay, so this was to show the case. Then we had a quick discussion about this. We just discussed it here, the limitations of TEER for this challenging case. This is the images that we got during the case. The TE performed just before starting the case. You see again the same anatomical characteristics with a very wide and a torrential mitral regurgitation in this case. Let me move on here. So here we discussed a little bit about the transeptal puncture. The transeptal puncture, I will stop here just to tell you a little bit about this. The transeptal puncture is a little bit different than we do for mitral clip. It can be more anterior, and we don't need that very high access in the left atrium. Around in between 3 and 4, around 3.5 is perfectly fine for this procedure. So this is the transeptal puncture I was just talking about. We don't need to be so high. It was 3.5 in this case, a little bit more anterior than we do for mitral clip, because we want to target the catheter goes to the posterior leaflet. So if you go a little bit more anterior, it's easier for us to have access. So this is 28 French OD crossing the septum, and then we steer we insert the implant, as you see here, It's being inserted into the transeptal sheath. And then we steer the catheter, and you're going to show the maneuver here. It's quite simple, that we steer towards the posterior annulus. Alex is explaining here how to do it. This is the steering of the catheter towards the posterior annulus. You bring it from this position down here to the posterior annulus to deploy and insert the primary anchor. So as soon as we get to the place we want, in the middle of the posterior annulus, we deploy the primary anchor. You see here 5 screws that are out, and now the implant is out of the catheter, sitting perfectly here on the annulus. You see the anterior leaflet moving freely and touching the implant in the posterior side of the mitral valve. Then at this moment, what we do, we check a mitral regurg, we check for gradients, and if we have a good result here, we can move on. See, the gradient was 3. We can move on and then start deploying the secondary anchors, as you're going to see here. First the rails, the 4 rails. Then the anchors.
You see, the piece of this procedure that takes a little bit longer is to find the perfect location for the primary anchor.
Yeah.
Everything else falls naturally. So it's become all these other steps are very, very easy. And just to make sure we have TE to see if the screws are touching the floor of the atrium.
So again, you check after you check gradient and MR. You can engage the secondary anchors, and it's quite simple, as Alex mentioned there. We're checking gradients here and MR.
Again, this is totally the point of return. So if you, for some reason, you have residual gradient, if there's still leakage, considerable leakage, you can retrieve everything.
So let's see the deployment of the secondary anchors right now.
Yeah, I think the beauty here is that you really have the chance before you release a device that you can actually really address everything. You can look for the gradients, you can look for residual mitral regurgitation, and if you're really sure, you'll have the same result if you release a device. So this is very reliable.
Yeah.
Nina, can I ask, as an imager, I mean, how difficult is this to visualize? I remember our cardioband days where we were trying to see 12 to 16 anchors, you know, going into the annulus, and it was very difficult. Is this easier?
Yeah, it's a lot easier. And as you already mentioned, I mean, the major point of the procedure is to really implant the primary anchor in the middle of P2. So this is one thing you have to address, and everything else can be orientated accordingly. So a much easier life than with a cardioband procedure, Azim.
So Nina, here I think we can clearly show the secondary anchors, then the drivers being removed, then the full release of the device. We check again for mitral regurgitation. Here we see that there's a very small lateral jet with the mean gradient is still 3, didn't change since the beginning of the procedure. And here side by side, you can see before and after the procedure. So almost abolishing mitral regurgitation. We have some leak at this lateral side here, but very, very mild, as compared to a torrential MR at the beginning, as you can see here. And also, in the other view, a 3-chamber view, you can see how it was before, baseline, And after the implant, you see the anterior leaflet coapting very well with the device here, with the implant here. So a very good result, excellent reduction in mitral regurgitation without increasing gradient in a situation of a small valve, as I mentioned, 3.6 square centimeters. So we would expect a much higher gradient with TEER, for example. So this is the case.
So thanks very much, Fabio, and thanks for giving us a running commentary instead of the sound. Just give us an idea of procedural duration, maybe not for the first case, but when you're familiar with the device.
Yeah. So far, we've done around 25 cases with this technology. And of course, the more you do, the better you get, the faster you get. So now, with these 20 patients treated, I think our procedure time it's not more than 1 hour. Okay. Not more than 1 hour.
So very, very quick.
We actually did this live case that we had 40 minutes to do it, and it was done in 40 minutes.
No, I remember it very well. Yeah. So, Uli, shall we hear your recorded case? Do you have one as well? Yes, maybe. Yeah, let's try. Let's try.
See if your voice is as beautiful as Fabio's.
I will raise the microphone for him.
Yeah.
This is a case we are now pushing a bit the envelope. So this is a DMR case, as opposed to the vast majority of cases that had been done before. So Nina is presenting on these 45 cases within the study. So there is now 3 cases with DMR, and this is a tape case of a degenerative mitral regurgitation. And we did it in my center.
It looks like we're expecting you to do some karaoke too.
Like 4 weeks ago.
You're going to be the first, Azim.
Ulrich, I noticed there's a guide and a coring wire down in all these cases. What's the rate of coring compromise that you've encountered?
Yeah, this we did for safety reasons.
Hello, a warm welcome here from the Hybrid in Bad Beven. Okay. Yeah, so far in the first series with the Gen 1, we had 1 coronary impingement, so we had to undo the wire, the anchor. But besides that, I'm not aware of any coronary accidents. But you have to check for the proximity of the coronaries. And you can also steer the anchors somehow if you are very close to prevent that you are artificially screwing the anchor inside the coronary. Hello, a warm welcome here from the Hybrid in Bad Bevensen, in the Heart Center here in Bad Bevensen. I think we have today an interesting case for you. It's going to be a Polares implantation. And we have here an 84-year-old female patient with severe mitral regurgitation, some tricuspid regurgitation, and only a mild impaired LV ejection fraction. She is in functional class 3. She has, as you can see later on, hypertrophic heart disease, most likely due to hypertension. So there's a mild HFpEF underlying, and she has mild coronary artery stenosis of the LED. There's also only mild pulmonary hypertension, and due to the symptoms of this patient, we had her 2 times for tendine screening, and there was found that the ventricle is too small, and there's also a high risk of left ventricular outflow tract obstruction. Despite the fact that we tried to increase the opening of the LVOT with the TASH, she was deemed, again, non-suitable for tendine. So taken together, there was no option for this lady, and we opted now for a Polaris device. Let's go to the echo images. So you can see here the reason why she was not suitable for AMP here. There's a stiff posterior leaflet. There's significant mitral regurgitation. You can see there is MAC. This is better seen in the CT later on. Here you can see the 3D images. And here you can see the hypertrophic disease with a very small ventricular cavum. And you can also see that there's a bulge of the proximal septum that maybe was the reason why there was a high risk for LVOT obstruction with tendine. So we did a TASH, as I said before. Here you can see the targeting, where we see that after contrast injection of the first septal perforator, that there is a nice identification of the target zone. And this led to a partial opening of the LVOT, but still a higher risk of LVOT obstruction with the calculated any neo-LVOT of 185 square millimeters, so still too small. And this is what we're doing today. So here you can see the implant. It's the MRace from the Polares medical company. And you can see that this device is basically placed on the posterior leaflet on top. And it's extending a bit the cooptation of the anterior leaflet. And the device is fixed with 5 anchors. And we're going to see this during the procedure very elegantly to the posterior annulus. There's extensive planning necessary before that. You can see here the calcification. You can see the device simulation in diastole and systole. And here you can see also the simulation of the 5 anchors for the posterior annulus. So the transeptal puncture is important and the primary anchor are very important. So I'm going across. Should be across. It's a little bit stuck here. Okay, good. So now we are going for an ACT of 250 and higher. And then I'm starting to give some curve. And maybe we have a 3D, yeah, that's nice. And then go posterior. Go a bit inside. Go a bit anterior before getting contact. Do we have contact?
So we check.
And the catheter is a bit bending, so there should be some pressure from below.
Nicht bewegen. Yeah, so this is about 70 millimeter if we go to the middle part of the catheter.
Okay. It's coming. So it fell into the anatomy. It might not be completely wrapping around the posterior leaflet. Maybe you check in 2D quickly. Pressure is good. No.
This looks good.
And the gradient, that we don't have any obstruction. That.
Okay, it's less than 1, so it's not a big gradient.
So all anchors are down. That looks promising.
Yeah, so we have a small residual jet here on the lateral side, medial, maximum, tiny.
So the beauty is that you can always go backwards until you reach the point of no return. All right, so then we continue with these secondary anchors. So you start with the medial inner. Give a little push, because there's calcium. 1, 2, 3. Okay. Lateral inner. So I do this basically fluoro-driven, huh? Because it's not giving us any readable image.
No, we don't get additional information from.
Okay, lateral inner. 1, 2, 3, 4. So lateral outer. 1, 2, 3, and medial outer. One, 2, 3. So all secondary anchors are pre-engaged. Last moment to decide if we continue or not. The medial part will get better once we screw the anchors fully inside.
Yeah, we have a little residual mitral regurgitation here on the medial
The most important thing is that we have no gradient.
Yes, that was fine.
So 1, 2, 3, 2, 3, 4, 5. 2, 3, 4, 5. Okay. 1, 2, 3, 4, 5.
So here we can see the device. So there are two small residual jets, medial and lateral, but pretty small. And what you can also appreciate, so this is the ACE, and this is the base of the device. So you can see flow in between the ACE. So here we see the final result after the implantation of the device. So what you can see on the left-hand side, that's the situation pre-implantation. So as you remember, we've seen these two deep indentations here in the posterior leaflet with two jets. And here you can appreciate the position of the device. And there's a small, really tiny residual mitral regurgitation here to the medial side. So altogether, it looks like a pretty reasonable result for this patient. And as you remember, the gradient was 3.8 before and 3.8 after the implantation.
Device time 70 minutes. It's like a mitral clip procedure. So taken together, I think it's really something that is interesting. And it's a big team. It's a team effort, as everybody can see. And thank you for your attention.
Thank you. I think that we should move fast to the last presenter. Nina is going to summarize the data so far. Thank you so much, Nina, with emphasizing the echo images.
Thank you so much for this kind introduction. So what are the clinical data? I mean, we are speaking about a patient group of 45 patients at the moment, which have been included in the Explore MR study. It's an early feasibility study. So the first patient was implanted in January 2024. So 4 centers are currently involved in this investigation, and the main inclusion criteria and exclusion criteria was that they looked for functional MR patients with an MR grade of at least 3. And the major exclusion criteria were anatomically. So the inclusion rate is pretty high with 70% of positive screen-in rates. So the patients, most of the patients have been highly symptomatic with a NYHA grade of 3 or 4. The average ejection fraction was 40%, and the majority of the patient had really severe mitral regurgitation of grade 4. So if you compare the results of the Explore MR study and with the latest generation of TEER devices, so we come to a pretty similar result concerning the mitral regurgitation. And also if you look at the gradients after the implantation of the devices, so this is pretty similar, most likely around 4 millimeter of mercury. So let's look at the clinical endpoints. Ejection fraction after the procedure, after a course of 1 year, is mainly sustained. Also, if you look at the symptoms of the patients, the NYHA classification, this is sustained for the entire year. And the 6-minute walk test also seems to be pretty stable over the course of 1 year. And if you look at the 1 year data, again, so if you look at the MR, at the grade of MR here, this is also sustained or more or less sustained over the year. The functional status of the patient is sustained. A 6-minute walk test, pretty stable over the time. The gradients are stable, which is a very encouraging sign, I think, that we don't get higher gradients over the time, and ejection fraction is preserved. And I think this is of major interest if you look at the remodeling of the patients. I mean, it's pretty clear that the diastolic volume is going down, but that the systolic volume is going down over the time. This really indicates that we get a positive structural remodeling of the left ventricle. So if you divide the patients in two groups, and as Sim, you nicely showed the complex criteria for TARE. So if you divide these patients in a group of non-complex and complex patients, you can also appreciate that the result for the complex patients, which would have been complex for a mitral TARE, have pretty good outcomes with this device over the time. So looking at safety outcomes, so there was something which has to be mentioned. There was one death during the procedure. This was due to due to a vessel problem, hemorrhage in the groin. And if you follow these lines here, all-cause mortality and cardiovascular mortality, they go in alignment. So this means most of the cases that had a death over the time, non-cardiovascular, 5 deaths, or cardiovascular deaths, 8 deaths, which seems a little bit high. But if you look at the patient groups, so most of these patients have been in a later stage they died. As you can see here, if you plot the ejection fraction, if you go back once, ejection fraction, and the systolic volumes. So these patients have been in this edge here, which means they had the highest volumes and the lowest ejection fractions. And we also have to mention that 2 patients have been on pump on the table, and these patients didn't make it. It was end stage, didn't make it through the course of the implantation. So if you summarize that, the Polaris device shows a reduction pattern similar to the Gen 4 mitral clip device, with improvement in the functional status and 6-minute walk test. So the cardiovascular deaths likely reflect advanced heart failure pre-treatment, underscoring the need for really strict screening of the patient and a good adherence to medical therapy. So we have seen that we can address even complex functional mitral regurgitation anatomy, but the device is not limited to this, so unlike TARE, for example. And the early results we've seen right now are promising, but for sure we need long-term data and to see if the device is really durable on the longer follow-up. Thank you very much.
So thank you, Nina. As you say, particularly impressive in screening, 71% acceptance, which is really very striking compared with other innovative devices. Martin, I saw you taking some careful notes. What do you make of these results?
I think it could be a new era for transcatheter mitral valve repair, right? I think it's looking like we may now finally have another tool beyond edge-to-edge repair. I think Ulrich's case was astonishing because I think we all have patients with these very calcified posterior leaflets with a lot of MAC. They're not surgical candidates. They're not transcatheter candidates currently, and this is the first time I've seen a solution for that.
And we've got some other questions here. Perhaps, Thomas, you would be best placed to address them. Firstly, could this have a role with calcific anatomy, or do you think calcified annulus or leaflets would preclude it?
Well, actually, we just have seen this very nice live case, a live-in-box case from Ulrich that's especially treatable, a very calcific anatomy. And I have to say, as a cardiac surgeon, especially in high-risk patients, calcified annuli are a bit of concern in some patients. This can end in a disaster when you have a destruction of the whole disintegration of left atrium to left ventricular continuity when you have to take out too much calcium. So rather place such a device depending on the situation that you can put in the screws. But Ulrich nicely showed us that this is feasible. So I believe it's a good indication.
And Azim, just coming back to you, sorry. Do you think there could be a complementarity? Could TEER also be undertaken in these patients with a Polaris device in place?
Yeah, I'm not sure. I don't think so. I think you don't want to grab onto a device like this. I'm not sure you're going to have stability of your clip. I think, one of the things that maybe impressed me from Nina's presentation was you said the 71% inclusion rate is also, I've not seen so many patients enrolled in a new technology in such a short time. I mean, just in over a year, they've enrolled 45 patients. And, me and Martin were involved in another posterior leaflet augmentation technology, where it took us a really long time to enroll less patients. I think that's impressive, and it's got to do for me with, I think, the fact that they're screening in so many patients. I'd love to know, just out of interest, the 30% who were screened out, what were the main reasons?
The main reason were issues with the anterior leaflet, because this is something you can't replace.
Okay. We have a question here. Thank you. Franz-Josef.
Really astonishing. I want to ask about the retrieval. As far as I have seen, there was no patience for retrieval of the device in the 46 cases, right? So screening first, and after that, when you decide retrieving after screening, do you have any conflicts about the, for example, the next step or the third step in terms of screening up and opening that back and into the calcification and pulling the device back again and landing to a different zone and screening again? Any concerns about the next steps after retrieving the device?
Uli, maybe that's best taken by you.
We should not talk too much about calcium because this is only one case so far. I think it's still early, but I think it's opening a nice future perspective. Retrieving is very simple. You just undo the anchors and you pull it back in the guide. But then you have to take the device out and you have to bring in a new device and to re-anchor if you want to exchange it to a larger device or a smaller device. So you can't, after retrieval, use the same device.
Okay, thanks, Uli. Alex?
Just to complement, the experience we had with retrieval was first generation, because the first generation first didn't have the ACE solution, so it was a little bit of bulkier, bigger device, and the main reason why you retrieved is residual gradient. So now with this current generation, at least from São Paulo, we didn't have any case to retrieve. But again, the cases we had, no problem. We just unscrew and take the thing out.
And finally, Azim, just thinking into the future, it's still relatively early days, but moving at an exciting rate of progress, as we've all agreed. Could you see a head-to-head trial with TIA?
Absolutely. I'm excited to start in the EFS, and we're going to start doing cases in the US, which I think is the first step. I think the next step then is a pivotal study. And again, when you look at these new technologies, you generally have two options for pivotal studies, right? You either say you're going to do only TIA-ineligible patients, so you can do single arm. But I really think when I see like some of the results, and I saw your case, Fabio, I mean, I couldn't get a result like that in that anatomy with TIA, right? So I think potentially I could see us randomizing against TIA. I think, the device seems safe. You have a bailout. It's not a long procedure. So I think why wouldn't you go head-to-head against TIA? In FMR, I think, right?
Yeah,
I mean, I think DMR,
sure.
there may be some DMR cases that could be also useful to this, where it's mostly on, posterior leaflet. But I think for me, right now, I'm thinking of this more as an FMR device, and I'd love to explore more. Also, can we, maybe in a subset of patients, look at, can we treat more calcified annulus patients who don't have stenosis and have a large enough mitral valve area?
And staying with the point of secondary, Nina very nicely showed the reduction in diastolic and systolic volumes as a consequence of MR ablation. So that was fantastic.
Yeah.
So Alex, do you want to bring us home?
No, I like to stay in Paris, if you allow me. But I think this was a great symposium, and it's a light at the end of the tunnel. Remember that we've been struggling. The whole road for mitral solutions were not so easy, has been not so easy as compared to aorta. I think that there is hope for an interesting alternative for the future. I think that if you want to give the final take-home message, Bernard, but I think that the enthusiasm towards new solutions for this very complex problem is naturally and slowly but surely being developed.
But now, can I say one other thing that we didn't talk about? Is, when you compare this to TIA, I mean, TIA for me is complex because every procedure is different. Every procedure, you're having to make decisions about where to put the device, put a second device. What I like about procedures like this, it's the same every time, right? That leads to a certain level of reproducibility, which I think is also really important.
And presumably shortens the learning curve as well. Absolutely. Exactly. So in conclusion, we've seen an exposition of data relating to an exciting new device in the mitral field, a device that will be flexible across a range of pathologies, that's complementary with existing approaches. I'd like to thank all of the speakers. I'd like to thank Fabio and Uli for sharing their cases. Apologies, Fabio, for the sound issue, but you did a wonderful job with your speakover. Thank you all for coming to this symposium. Thank you to Polares for supporting us. And I wish you all a fantastic remaining few days here in Paris. Thank you.